The doctor told you the treatment would save your life. You believed him because he was the only person in Tudor England who claimed to understand what was happening inside your body. He was trained, he was confident, he had done this before. So you let him open your vein and drain your blood into a bowl. You swallowed the pill that made you vomit until your ribs cracked. You sat naked in a sealed room while mercury vapor filled your lungs because he said the poison would cure you. And when your gums turned black and your teeth fell out and your hands began to shake so badly you could not hold a cup, he told you it was working. It was not working. It was killing you. Slowly, methodically, with the full backing of every medical institution in England. But here is what no one ever tells you about Tudor medicine. The doctors were not fools. They were not criminals. They were intelligent, trained, dedicated men who followed the best science available to them. And that science was wrong. Not slightly wrong, catastrophically wrong. Wrong in a way that turned every treatment into a weapon and every sick room into a death sentence carried out by the only hands the patient trusted. The cures you are about to hear were real. The suffering they caused was documented, and the people who endured them had no way of knowing, no way at all, that the hands trying to save them were the hands that would destroy them. The room smells of vinegar and something worse, something sweet and metallic underneath, the kind of smell that stays in wool and plaster for weeks. A woman lies on a bed in a house off Cheapside. Her name does not survive in the record, though her case does because the surgeon who treated her wrote it down. She came to him with a fever, a common fever, the kind that passes in a week if the body is strong enough and the season is mild. But she went to a surgeon, and the surgeon did what surgeons did. He bled her on the first day, opened a vein at the crook of her elbow with a Fleam, a small spring-loaded blade designed for exactly this purpose, and drew off what he judged to be an appropriate quantity of blood. She was feverish, so the logic was straightforward. Fever meant excess heat meant excess blood, and the remedy was removal. Take the blood out, let the body cool. She did not improve. On the second day, he purged her. A dose of antimony dissolved in wine to induce violent vomiting, followed by a purgative to empty the bowels. Aloes, senna, colocynth, substances powerful enough to cause cramping and fluid loss so severe that a healthy person would have struggled to recover, let alone someone already weakened by fever and blood loss. She worsened. On the third day, he bled her again. And on the fourth, when she could no longer keep water down and her pulse had grown faint and rapid, he applied a blistering plaster to her chest. A paste of cantharides ground from dried blister beetles, which raised the skin into weeping blisters that the physician believed would draw the remaining poison to the surface. She died on the fifth day. The cause recorded fever, not treatment, not blood loss or dehydration, or the cumulative shock of 5 days of medical intervention inflicted on a body that had needed nothing more than rest, water, and time. Fever. As though the disease alone had done this. And here is the part I keep returning to after years with these sources. Nobody in that room, not the surgeon, not the family, not the neighbors who came afterward, had any reason to believe the treatment was the problem. The surgeon followed the standard of care. He did what he had been trained to do, what the textbooks prescribed, what every other surgeon in London would have done in the same circumstances. He was not negligent. He was not cruel. He was competent, experienced, and wrong. And the system he operated within had no mechanism for telling him so. That woman off Cheapside did not die of fever. She died of medicine. Now, how did a system designed to heal become a system that killed? The answer begins not with incompetence, but with a theory. A theory so elegant, so internally consistent, so deeply embedded in every institution of European learning that no one alive had the tools to see past it. The theory was called humoral medicine. It rested on the idea that the body contained 4 fundamental substances: blood, phlegm, yellow bile, and black bile. And that disease was caused by imbalance among them. Too much blood caused heat and fever. Too much black bile caused melancholy. Too much phlegm caused cold, sluggish conditions. Every diagnosis followed from this framework. Every treatment was designed to restore balance by removing the excess through bleeding, purging, vomiting, sweating, or blistering. The reasoning was meticulous, the anatomy was imaginary, and the framework had been refined for over 1,500 years, from Hippocrates in the 5th century before the Common Era through Galen in the 2nd century, transmitted through Islamic scholarship during the medieval period, and taught at every university in Europe without meaningful challenge. The logic was flawless. The premise was wrong. And because the premise was wrong, every treatment that followed from it, every bleeding, every purging, every dose of mercury, was not restoring balance. It was destroying what remained of a body already fighting to survive. But no one knew that. Not the physicians who trained for years at Oxford and Cambridge, memorizing Galen in the original Greek. Not the barber surgeons who opened veins 6 days a week in shops marked by the red and white pole that still hangs outside barbers today, red for the blood, white for the bandages, though most people have forgotten why. Not the apothecaries who ground mercury and antimony into pills and pastes with the same care a modern pharmacist brings to filling a prescription. They were all working inside a system. The system was the problem, and the system was invisible to everyone inside it. The woman off Cheapside was one of thousands, tens of thousands, who shared that fate across Tudor England without anyone recording the distinction, because the distinction did not exist in any framework available to the people who could have made it. The physicians who killed her were not the last to do so. They were not the worst. And the treatments that followed, the ones you are about to hear, make what happened in that room off Cheapside look almost gentle. The disease arrived before the cure did, and it arrived fast. Syphilis reached England sometime in the last years of the 15th century, carried, according to the popular theory of the time, by soldiers returning from the Italian wars, though the precise route of transmission remains debated by historians and epidemiologists to this day. What is not debated is the speed. By the 1520s, syphilis was endemic in London. By the 1540s, it was one of the most common conditions treated at the city's hospitals. William Clowes, a surgeon at St. Bartholomew's Hospital, wrote in 1579 that of every 20 patients admitted to his care, 15 were suffering from what he called the morbus gallicus, the French disease. 15 of 20. 3/4 of the beds in one of London's largest hospitals, occupied by a single illness that had not existed in England a century earlier. And the standard treatment was mercury. Not a derivative, not a compound that happened to include mercury among other ingredients. The metal itself, quicksilver as they called it, applied directly to the body in concentrations that would be classified as acutely toxic by any modern standard. The methods varied, but the intent was always the same. Get the mercury into the patient by whatever means necessary and keep it there until the disease relented. The first method was inunction. The patient was smeared with a grey ointment, mercury mixed with animal fat, sometimes with added herbs or spices to mask the smell, and the paste was rubbed vigorously into the skin of the arms, legs, chest, and back. The rubbing was essential. Friction opened the pores, according to the theory, and allowed the mercury to penetrate deeper into the flesh where the disease was believed to reside. The treatment was repeated daily, sometimes twice daily, for weeks. The patient's clothing and bed sheets became saturated with mercury residue. The room itself became toxic. The second method was fumigation. And this was worse. The patient was placed inside a wooden barrel or a small enclosed space, sometimes a tent of heavy fabric, sometimes a sealed closet barely large enough to sit in. A dish of mercury was set on hot coals beneath them. As the mercury heated, it released a dense, invisible vapor that filled the enclosure. The patient sat naked, breathing the fumes, for as long as the physician prescribed, sometimes 30 minutes, sometimes an hour, sometimes longer. The heat made the skin flush and sweat. The mercury entered through the lungs, through the open pores, through the mucous membranes of the eyes and mouth. There was no ventilation. There was no escape from the vapor except to end the session, and the physician, not the patient, decided when the session ended. Imagine that. Sitting inside a sealed box, naked, while poison heats beneath you and fills the air you breathe. Your physician standing outside, listening, timing the session, and believing with complete sincerity that what he is doing will save your life. The third method was oral. Mercury pills, mercury solutions, mercury mixed into syrups or dissolved in wine. These entered the stomach directly and were absorbed through the gut lining, passing into the blood and from there to every organ in the body. The dose was imprecise, the effects were not. What mercury does to the human body is systematic and devastating. The first visible sign was the mouth. Within days of beginning treatment, the gums swelled, reddened, then darkened. They bled at the slightest touch. The tissue between the teeth began to break down, a process called necrosis, and the teeth loosened in their sockets and eventually fell out. The tongue swelled so dramatically that some patients could not close their mouths, and then came the salivation. This was the part that the physicians watched for. Mercury stimulates the salivary glands to an extraordinary degree, the body's attempt to flush the poison out through any available channel. Saliva poured from the mouth in quantities that contemporary accounts describe in terms of pints per day. The patient drooled constantly, uncontrollably, soaking their clothes and bedding. The fluid was thick, sometimes bloody, foul-smelling. And the physicians, this is the detail that stays with me, considered the salivation a sign of success. They called it botulism and they measured it. The more saliva, the more effectively the mercury was believed to be driving out the disease. Some practitioners set a target. The treatment would continue until the patient had produced a specific volume of saliva, sometimes measured in pints per day over a period of weeks. The salivation was a symptom of poisoning. They treated it as evidence of cure. Beyond the mouth, the mercury migrated. The kidneys, which filter toxins from the blood, were damaged early and often irreversibly. The nervous system followed. Tremors in the hands first, then the arms, then the whole body. The tremors became so closely associated with mercury exposure that the phrase "mad as a hatter" entered the language centuries later, describing the neurological damage suffered by hatmakers who used mercury in the felting process. But the hatters came after. The syphilis patients came first. Memory loss, confusion, personality changes, paranoia, hallucinations. These were the later stages of mercury poisoning, symptoms that, in the context of syphilis treatment, were easily attributed to the disease itself, since tertiary syphilis produces its own neurological devastation. The overlap was tragically convenient. A patient whose brain was being destroyed by mercury looked to the physicians exactly like a patient whose brain was being destroyed by syphilis. The treatment was invisible inside the disease it claimed to cure. And here is the cruelty of the paradox. Mercury did have some effect on syphilis. Not a cure, nothing close to a cure, but a temporary suppression of symptoms. The skin lesions receded, the rashes faded. The patient appeared, for a time, to improve. This intermittent success was enough. It was enough to sustain belief in the treatment for generations because the temporary improvement was visible and immediate, while the long-term poisoning was slow, cumulative, and attributed to other causes. Clowes himself documented cases with meticulous detail, the progression of symptoms, the treatments applied, the outcomes. He was a careful observer and a skilled surgeon. He was also, like every practitioner of his era, unable to see the treatment as the source of harm. The framework would not allow it. Mercury was the remedy. The disease was the enemy. If the patient worsened, the disease was winning. If the patient died, the disease had been too advanced. The cure was never questioned because the theory that justified it was never questioned. 15 of 20 patients bled, purged, and poisoned with mercury. Recorded as victims of syphilis, never recorded as victims of medicine. The Fleam was small enough to fit in a pocket. A folding blade, spring-loaded, with a sharp triangular point designed to puncture a vein cleanly and quickly. One motion, a flash of steel, and the blood began to flow. Barber surgeons carried them the way a carpenter carries a hammer. It was the most basic tool of their trade, used more often than any other instrument, on more patients than any other procedure, for more conditions than any modern physician would believe possible. Headache, fever, plague, melancholy, mania, gout, dropsy, consumption, pregnancy complications, grief. Bloodletting was not a treatment for specific diseases. It was the treatment, the default, the reflex, the first and often the only medical intervention available to the vast majority of the English population between the 15th and 17th centuries. If you were sick and you sought help, you were bled. The question was not whether to remove blood, but how much, from which vein, and on which day, because the timing mattered too. Astrological charts guided the decision. Certain veins corresponded to certain organs. Certain days were favorable, others dangerous. The system had rules, and the rules were followed with the seriousness of law. But the blood was real, and the bodies it came from were already failing. Thomas Eliot, writing in 1539 in his widely read manual The Castell of Health, recommended bloodletting for an extraordinary range of conditions. His instructions were detailed, confident, and entirely consistent with the humoral logic of his time. Fever indicated excess blood generated excess heat, and the removal of blood would restore the body's natural balance. The reasoning was impeccable, the physiology was imaginary, and the patients bled. How much blood? The answer depended on the practitioner, the patient, and the severity of the complaint, but the quantities were not trivial. Common practice called for 8 to 16 ounces per session, roughly a pint, and sessions could be repeated every few days if the condition persisted. Some physicians prescribed more aggressive courses, multiple bleedings in a single week, each drawing off enough blood to leave the patient pale, faint, and barely able to stand. The idea was that weakness itself was therapeutic. If the patient felt drained, the treatment was working. Strength would return once the balance was restored. It did not return. Not for everyone, not nearly often enough. A patient with an active infection needed every drop of blood in their body. The immune response, a concept that did not exist in Tudor medical theory, depended on white blood cells carried in the blood to the site of infection. Remove the blood, and you remove the defense. A patient bled during a fever was not being treated. They were being disarmed. Their body's only weapon against the disease was being drained into a bowl and discarded, and the physician standing over them believed he was performing a service. I cannot tell you how many people this killed. That's the honest difficulty with this subject. The records do not separate death by disease from death by treatment. A patient who was bled 3 times for a fever and then died was recorded as having died of fever. A patient who was purged to the point of collapse and then stopped breathing was recorded as having died of whatever illness brought them to the surgeon in the first place. The treatment vanishes in the record. It leaves no trace, not because it was harmless, but because the people keeping the records had no category for the harm it caused. You cannot count what you cannot see. And they could not see it. Purging was the partner to bloodletting, the other half of the humoral arsenal aimed at the other end of the body. Where bleeding removed excess from the blood, purging removed corruption from the gut. The methods were violent. Emetics to induce vomiting. Antimony was the most common, a metallic compound that irritated the stomach lining so aggressively that the body had no choice but to expel everything inside it. Purgatives to empty the bowels, aloes, senna, colocynth, scammony, each one powerful enough to cause cramping and diarrhea lasting hours, sometimes days. The goal was total evacuation. The corrupt humours had to come out. Every exit was used, and the two were combined, routinely. A patient might be bled in the morning and purged in the afternoon, or bled on Monday, purged on Tuesday, bled again on Wednesday. The cumulative effect, blood loss plus dehydration plus the shock of repeated violent evacuation on a body already weakened by illness, was something the modern term iatrogenic was invented to describe. Harm caused by the healer. The case that lodges in my mind is not dramatic. It is ordinary. A man in his 40s, the record comes from a barber surgeon's casebook, the kind of source most people never see, presenting with what sounds, from the description, like a moderate chest infection. Cough, fever, difficulty breathing. He was bled on the first visit, bled again 2 days later. Purged with antimony on the third day, which produced, the surgeon notes with clinical detachment, violent vomiting lasting several hours followed by severe looseness of the bowels. Bled a third time on the 5th day. He died on the 7th. The surgeon recorded the death without comment. No reflection, no doubt. The patient had died of his chest complaint. The treatment had been appropriate, timely, and correctly administered. There was nothing more to say. 7 days, 3 bleedings and a purging, administered to a man whose body needed rest, fluid, and the chance to fight the infection on its own terms. He received the opposite of every one of those things. And the man who killed him, though he would never have recognized that word, and I use it carefully because intent matters and his intent was to heal, went on to his next patient and did exactly the same thing. That is what makes this difficult to sit with. Not the violence of the treatment, not the suffering of the patients, the normalcy, the complete, unremarkable, day-after-day normalcy of a medical system that was killing the people it was designed to save, carried out by professionals who were doing their best, recorded by clerks who saw nothing unusual, and mourned by families who blamed the disease and never once looked at the man with the fleam. The red and white pole still hangs outside barbers today. Most people walk past it without a thought. There is a point where medicine and vanity become the same thing, and Tudor England crossed it so thoroughly that the line disappeared altogether. Consider ceruse, white lead, a paste made by dissolving lead in vinegar. The same chemical compound, essentially, that was used in house paint until governments around the world banned it in the 20th century because of its toxicity to children who touched the walls. Tudor women applied it directly to their faces, every morning, for years. The logic was straightforward. Pale skin was the beauty standard, not just fashionable, structural. White skin signified wealth, leisure, distance from outdoor labor. A woman whose face was brown from the sun was a woman who worked in fields. A woman whose face was white was a woman who did not. The distinction was social before it was aesthetic, and the pressure to conform to it operated at every level of society, from the merchant's wife who could afford a small pot of ceruse to the queen who had it applied by her ladies-in-waiting every morning as part of the ritual of dressing. The product worked. Lead white is an effective pigment, opaque, smooth, adhesive to skin, capable of creating the porcelain complexion the period demanded. No alternative came close. Chalk was too dry, too powdery, too impermanent. Rice powder was ineffective. Ceruse held. It smoothed imperfections. It covered blemishes, scars, the redness of rosacea, the pockmarks left by smallpox. For a woman whose face had been damaged by disease, and in Tudor England that meant a significant percentage of the adult female population, ceruse was not vanity. It was armor. But the lead did not stay on the surface. It absorbed through the skin slowly with each application. Lead is a cumulative poison. It does not flush out. It builds in the blood, in the bones, in the soft tissue of the brain and kidneys. The symptoms come gradually over months and years. headaches that worsen and do not respond to any remedy. Abdominal pain, what the period called colic, severe enough to double a person over. Constipation, muscle weakness starting in the hands, spreading to the arms and legs. Irritability, confusion, memory loss. And then, in the later stages, kidney failure, seizures, and death. And here is the trap, the part that makes this more than a curiosity. The lead damaged the skin. Chronic lead exposure causes the complexion to grey, to roughen, to age prematurely. The very product designed to create beautiful skin was, over time, destroying it, which meant the woman needed more ceruse to cover the damage caused by the ceruse she had already used. A cycle with no exit, each application concealing the harm of the last. Each morning, a fresh layer of poison on top of the damage left by yesterday's. Elizabeth I is the most famous example, though her case illustrates a broader pattern rather than an exception. After surviving smallpox in 1562, an illness that nearly killed her and left her face permanently scarred, Elizabeth began using ceruse regularly to conceal the marks. She continued for the remaining 4 decades of her life. The ambassadorial dispatches from her final years describe a woman whose appearance had deteriorated dramatically. Hair loss, blackened teeth, skin that appeared aged beyond her years. Some of this deterioration was natural. She was in her late 60s, an advanced age for the period. But chronic lead poisoning produces precisely these symptoms, and 4 decades of daily application makes it not just possible but probable that the ceruse contributed to her physical decline. And Elizabeth had the finest ceruse available, the purest lead, the most carefully prepared compound. Ordinary women buying cheaper mixtures from apothecaries or making their own from recipes that circulated in household manuscripts were often working with cruder preparations that contained higher concentrations of lead and additional contaminants. The damage was worse, the cycle was faster, and the women who suffered it had no physicians monitoring their condition, no one to connect the headaches and the weakness and the colic to the paste they applied to their faces each morning. Mercury appeared here too, not just in the treatment of syphilis, that was Part 2's territory, but in cosmetics. Quicksilver was used in preparations designed to treat skin blemishes, freckles, and discolorations. Applied to the face, it produced a temporary brightening effect. Applied repeatedly, it produced mercury poisoning, the same cascade of symptoms described earlier, played out on a smaller scale but no less destructive. Gum damage, tooth loss, tremors, neurological decline. A woman treating a blemish on her cheek could, over months of application, lose her teeth, her coordination, and her ability to think clearly. For a blemish. Arsenic compounds found their way into the cosmetic supply as well, sometimes deliberately as a skin whitening agent, sometimes as a contaminant in pigments used for clothing and interior decoration. The green dyes fashionable in Tudor dress frequently contained arsenic-based compounds. Chronic low-level exposure through skin contact with dyed fabrics is difficult to quantify at this distance, but the symptoms of arsenic poisoning, skin lesions, peripheral nerve damage, organ failure appear in the medical records of the period with a frequency that suggests a source beyond diet and water alone. What unsettles me about this section, and I have spent longer with these household manuscripts and apothecary records than is probably healthy, is not the toxicity. Toxicity can be explained. What cannot be explained away is the system that made it inevitable. The beauty standard demanded white skin. The only effective product was poisonous. The poison damaged the skin. The damaged skin required more product. No one in Tudor England had the chemical knowledge to identify lead as a cumulative toxin, and no institution existed to test cosmetic products for safety. The women who used ceruse were not making an informed choice between health and beauty. They were making the only choice available, inside a system that offered no safe alternative and no information about the risk. The system created the demand. The system supplied the product. The system concealed the harm. And the women who lived inside the system paid for it with their faces, their health, and, in the severe cases, the ones the parish registers record without explanation, their lives. Elizabeth survived into her 70s. Many did not. And the parish clerk who recorded their deaths wrote fever or colic or decline, because the word poisoning implied a perpetrator, and the perpetrator was a pot of face cream sitting on the dresser, applied that morning by the dead woman's own hand. Step back from the individual treatments. Step back from the mercury and the fleam and the lead paste and the antimony pills. Look at the whole of it, the entire framework, and ask the question that none of them could ask. Why did this continue? Not for a year, not for a decade, for centuries. Generation after generation of physicians, surgeons, and apothecaries applying treatments that weakened, poisoned, and killed their patients, with skill, with confidence, with the full institutional backing of the universities, the guilds, and the crown, and never once recognizing that the system itself was the source of the harm. Why? The answer is not ignorance. That is the easy explanation, and it is wrong. Tudor physicians were not stupid. Many of them were brilliant. They read Greek and Latin. They studied anatomy with a rigor that would exhaust a modern medical student. They observed their patients carefully, recorded symptoms in detail, and debated treatment with a seriousness that any modern clinician would recognize. William Close, whose syphilis cases fill part 2 of this documentary, was a meticulous observer. His case notes are precise, thoughtful, and demonstrate genuine care for his patients' well-being. Thomas Eliot, whose Castile of Health guided treatment across England, was a learned and conscientious writer who wanted ordinary people to understand their own bodies. These were not charlatans, they were professionals. And the theory they worked inside, humoral medicine, was not a folk superstition. It was the most sophisticated medical framework available anywhere in the Western world. Developed by Hippocrates in the 5th century before the Common Era, refined by Galen in the 2nd century, transmitted through Islamic scholarship during the medieval period, taught at every European university, and validated by 1,500 years of clinical practice. The Humours made sense. The logic held. If the body was a balance of 4 substances and disease was caused by imbalance, then the treatment, restore the balance by removing the excess, followed as naturally as arithmetic. The problem was not the reasoning. The problem was the premise. The 4 humours do not exist. Blood, phlegm, yellow bile, and black bile are not the fundamental substances of the human body. Disease is not caused by their imbalance. And the treatments designed to correct that imbalance, bleeding, purging, vomiting, sweating, mercury, antimony, were not restoring anything. They were damaging bodies that were already damaged, removing defenses that were already strained, and introducing poisons into systems that were already failing. But here is what I think people miss about this, and what years with these sources have taught me. The theory could not be disproved from inside itself. That is the crucial point. Humoral medicine had an answer for everything, including its own failures. If a patient was bled and recovered, the bleeding had worked. If a patient was bled and died, the disease had been too advanced for the bleeding to save them. If a patient was purged and improved temporarily before relapsing, the purging had been insufficient. More was needed. If a patient refused treatment and recovered on their own, they had been lucky, or God had intervened, or their humours had rebalanced naturally, which proved the theory was correct, because balance was the goal all along. There was no outcome that could falsify the framework. Recovery proved it worked. Death proved the disease was stronger. Spontaneous healing proved the principle. The system was sealed, airtight. And because it was airtight, it was unchallengeable, not by observation, not by experience, not by the accumulating bodies in the parish registers that no one thought to count in the right way. The institutions reinforced the seal. The College of Physicians, founded in 1518, regulated medical practice in London. Its purpose was to maintain standards, which meant, in practice, maintaining orthodoxy. A physician who challenged humoral theory risked censure, loss of license, professional ruin. The universities taught Galen. The examinations tested Galen. The guild system enforced conformity among the barber surgeons and apothecaries. Innovation was not just discouraged, it was dangerous. There were dissenters. Paracelsus, born Theophrastus von Hohenheim, a Swiss-German physician working in the early 16th century, challenged the entire Galenic framework. He argued that disease was caused by specific external agents, not by internal imbalance. He advocated for treatments based on chemical observation rather than ancient authority. He burned Galen's texts publicly in front of his students as an act of intellectual rebellion. And he was expelled from his position, mocked by the medical establishment, forced to wander from city to city, and died in obscurity in 1541 at the age of 47. His ideas would eventually contribute to the foundations of modern pharmacology. But not in his lifetime, not in Tudor England, not in time to save a single patient from the Mercury, the Fleam, or the antimony. And what of the patients themselves? This is the part that stays with me longest after everything else fades. The patients had no alternative framework. None. If you were sick in Tudor England, genuinely sick, frighteningly sick, the kind of sick where you could feel your body failing and you did not know why, you went to the physician, the surgeon, or the apothecary. Or you went to a folk healer, a cunning woman, an herbalist whose remedies were sometimes gentler but rarely more effective and occasionally just as toxic. Or you prayed. Those were the options. There was no second opinion that existed outside the humoral system because no other system existed. The choice was not between good medicine and bad medicine. It was between bad medicine and nothing. And most people facing that choice, facing pain, facing fear, facing the possibility of death, chose the medicine. Because the alternative was to lie in bed and wait, alone, with no one who claimed to understand what was happening to your body. They trusted the only hands available, and those hands, skilled, trained, sincere, confident, were, more often than anyone alive could have known, the most dangerous thing in the room. The Parish Registers sit in county record offices across England. Thousands of them, leather-bound volumes, some crumbling, the handwriting fading, the ink turning brown. They record names, dates, causes, fever, ague, flux, dropsy, decline. They do not record what treatment was given. They do not record how many pints of blood were drawn, or how many doses of antimony were administered, or how much mercury was rubbed into the skin in the weeks before death. That information, the information that would allow us to calculate, even approximately, how many Tudor patients were killed by their medicine rather than their disease, does not exist. It was never recorded. Because the distinction was invisible to everyone who held the pen. The gap between dying of illness and dying of treatment was real. It was enormous, and it was invisible, not because the evidence was hidden, but because no one alive had the framework to see it. The theory said the treatment was correct. The institutions said the theory was correct. The physicians, the surgeons, the apothecaries, all of them, working with dedication and skill and genuine compassion, followed the theory, applied the treatment, and recorded the deaths as casualties of disease. They were wrong. They could not have known they were wrong. And the people who trusted them, the woman off Cheapside with her fever, the syphilis patient in the Mercury barrel, the man bled 3 times in a week for a chest infection, the woman applying ceruse to her face every morning, had no way at all, to protect themselves from the confidence of the people trying to save them. The medicine was the deadliest thing in the room, and the room had no door.